Well, just to tell you some bit about that 10-year-old photograph that you put up. So it turns out not only did I build a linear accelerator, I was the only fourth grader to build a linear accelerator, and the Van de Graaff generator, but I was maintaining it for the science fair. I had unplugged it. And I was holding the output leads when somebody said, oh, look, there's a cord unplugged, and plugged it in. And since that time, my hair has been curly. So that's actually what happened. Very bad. Don't try this at home. Well, thanks so much for inviting me here. What an amazing journey we have all had. So Chuck said, 4 years ago, that Argonaut project came to be. And I think probably many of you know what actually happened that led to that. Now, obviously, FHIR has been around for 8 years, and there's been extraordinary work by so many important people getting us to the FHIR standard. But it went something like this. In 2014, President Obama was very dissatisfied with the interoperability progress that we were making in the country, so he committed that super secret organization, the Jasons, to figure it all out. Now, did the Jasons interview Cerner, Epic, Meditech? No, they interviewed Apple, Facebook, Google, and said, how did you create an ecosystem of app developers and create this excitement of building what will be layers of small apps coming out of garages that go onto your transactional systems? And they wrote a scathing report, which many of you may have read, the Jason report, which basically said all of us in healthcare are just stupid. That we're using these wacky standards that have ampersands and pipes and carets, and what were we thinking? That we should embrace JavaScript object notation and REST and OAuth and OpenID and these sorts of things. So that report came out. Many folks in Washington who were at standards meetings, you were there, were very embarrassed because we just felt chagrined that we were all so dumb. And so what did? We went to that Greek restaurant on D Street, the Agora, the meeting place, and we had hummus. And over hummus, we said, if we want to follow the Jasons, let's call ourselves the Argonauts. Golden Fleece, kill the Gorgons, all that other mythology stuff. And from that time, 4 years ago, to Apple, including the Argonaut standard in iOS worldwide. I mean, that's amazing. You just don't see this kind of standards adoption. At least in my life, I have never seen this meteoric rise. Well, before I came up, I was talking to Graham Grieve, and I said, Graham, what do you want me to say? And he said, well, a lot of people worry that the hype around technology will lead us from that peak of inflated expectations to the trough of disillusionment. And how do we avoid that problem with FHIR? Well, the answer is you're going to solve business problems, real business problems that affect people. And looking at the ages of folks in this room, my bet is there are some of you who are the care navigators for your family. That you're caring for those above you, caring for your peers, and caring for kids or those below you. So let me start with just a few use cases from my personal medical experience as to why FHIR is so important and where you need to go with it. So folks may know that 20 miles to the west, I run an organic farm, 250 animals, Unity Farm Sanctuary. It's got a 12-node Google Mesh network, gig fiber to all the barns, and you can stream all the animals 24 hours a day. So you'll find it on the website. My wife was diagnosed with stage 3A breast cancer in December of 2011. It's actually one of the reasons we founded the farm. And she, of course, had chemotherapy, radiation, surgery, did fine. But, as is in the case with breast cancer in general of her type, estrogen positive, she has to be on estrogen suppression for a decade or so. That's what the current evidence says. So she's on depot Lupron every quarter, 22 milligrams. Oh, and by the way, Chuck, unless you worry, my wife and I actually have notes in the compliance office noting that we'll talk about medical records publicly, and there's no HIPAA issues, no GDPR issues. Don't worry, it's all okay. So imagine her shock when she got a letter 6 months ago from her insurance company that said, we are no longer going to fund your depot Lupron. Well, why? Because our medical director, who's a retired psychiatrist in New Hampshire, read a paper from 1990 that suggests that 11 milligrams of depolupron is the right dose, and your wife is getting 22, because that's what the Harvard Partners, Dana-Farber Cancer Center, and hundreds of oncologists thought was a good protocol. So I did what any of you would do, which is I called the CEO of the insurance company and said, you know, those of us in academia tend to write a lot of articles, and I've actually just penned a perspective piece for the New England Journal of Medicine called The Total Failure of Care Management, and I've included a copy of your letter. And maybe, would you like to collaborate on how this could have been done better? And he said, yeah, actually, let's review why it was that we denied a drug which was actually decided upon by doctors and patients and experts based on literature for, actually, you'll love this, 13 Norwegian women. My wife, you can see, is Korean. And, you know, maybe the drugs for Norwegian women work the same as Korean women or not. No one knows. Well, what we talked about was, shouldn't every insurance company, through a FHIR interface, have the ability, with appropriate consent and privacy controls, to actually understand a little bit about the care of the patient? What is their medical record, their problems, their meds, their allergies? What are some of the notes, right? Because we need to actually look at context of the treatment, maybe even patient consent or treatment preferences. And then be able to say, I see, based on data, looking at the patient's history, that I can actually say something about whether or not this protocol is appropriate or no. Or have some ability to communicate with the provider team, look at the protocol that was used and the justification for the protocol. Or be able to actually look at evidence beyond a 1990 journal in the Bulgarian Journal of Irreproducible Results, right? And see what it is actually others have experienced. Or how about, imagine this, it turns out Harvard has 17 hospitals. They don't like each other very much, but they do at times share data. Shouldn't we be able to actually look at all the patients like my wife, and even without patient identifying details, don't need their names or zip codes or anything, say, well, what were the treatments they got, the outcomes they got? What was the morbidity and mortality? And shouldn't that inform the protocol? So, of course, yes, I did write the piece, and I did post blogs and all the rest. And this was, of course, not at all what I intended. They immediately reversed all their decisions for my wife, but more importantly, they reversed the decisions for every cancer patient going forward, that they won't make arbitrary decisions based on literature out of date. And in fact, the retired psychiatrist is no longer reviewing cancer cases. Well, good, good. And they have agreed that they do want to work with you, work with a community of developers and figure out how payers, which really are the friends of providers. I know we may not always think that way, but they're two sides of the same coin, right? At least in the US, our employers, and to some extent ourselves with employee share, pay for the care. We go through a payer or an intermediary, and the payer has to go with the provider and figure out all this reimbursement and all the rest. So it is an ecosystem that needs to be connected. So therefore, payers and providers should have FHIR hooks clinical decision support access to the great literature on cancer care or other diseases, should have access to that data, individual and aggregate, that is accumulated across the country. And there should be apps that consume this. I mean, just as Apple has created its APIs that help the patients and their families navigate this process. And ideally, when we started to connect the payers and the providers and the patients in this way, there won't be a lot of argument. It will be protocol driven. And that is, the payer will say, oh, as long as you follow a certain pattern and we share data and we are transparent, that your healthcare will be reimbursed, right? I mean, that's where we want to get. Now, see, you're from Europe, so I don't know. But, you know, we don't actually have a healthcare system here. What we have is disconnected hospitals and clinics and pharmacies and labs and insurance companies, and very rarely do any of these actually coordinate the care. And it's so important based on my own experience helping my wife with her cancer care that we do better. And FHIR really is the way to solve these workflow problems. But more globally than just my wife's issue, what am I seeing? So I travel 400,000 miles a year, Chuck, probably like you. And so in the last couple of weeks, I've been in China and Israel and Dallas and Seattle, and I'm seeing across cultures, and even in the United States, across our various regions, that there's this belief that although our EHRs are fine, right? I mean, doctors may not like them totally, but they're fine, that the innovation is really going to come from you guys. It's going to come from folks at hackathons, two people in a garage who are 26 years old who see a problem to be solved and need the ability to get data in and out of an EHR. So that's fine. The EHRs will be compliance tools and regulatory tools and will keep us getting reimbursed, but we need a lot of innovation at the edges, things that layer on top. And let me give you just some simple examples. So a few months ago, a young woman from Babson, an entrepreneurial college just to the west, said, do you know that Zimmer Corporation, Zimmer Biomet, makes knees, hips, other implants, spends $10 million a year on FedEx? Well, why? So it turns out you need a knee replacement. How do we get the knee to the OR when you need it? The answer is email, phone, fax, smoke signals, and Morse code. I mean, literally, there is no electronic coordination of the supply chain, of the surgeon, of you, and your implant. And so these companies in the supply chain, at the last possible moment, are FedExing material worldwide. Now, what if, let's say, there's a FHIR API for the OR schedule? Doesn't even need to expose who you are, right? Just the fact that tomorrow, 9 a.m., size 3 knee needs to be in this OR with this surgeon. Wouldn't you be able to revolutionize the way we coordinate care in hospitals and ORs, reducing cost for the hospital, reducing cost for the provider, reducing costs, of course, throughout the supply chain? I didn't know this, but it turns out Beth Israel Deaconess has 4 full-time equivalents just pushing faxes, email, and phone messages around for the coordination of OR supplies. And so this young woman from Babson created an app, asked if I would use, it's not quite the Argonaut spec for scheduling because it's the OR schedule a little bit different, but close. And we exposed that API to her app. It's live today. And the Zimmer Biomet reps now on their phones have the ability to see what devices are needed in what OR to coordinate care and reduce cost. This all took a few weeks, right? This wasn't waiting till 2022 when the next version of some EHR included it. It was a young woman at Babson with an idea. And you can imagine if these young people say, well, Zimmer, you spent $10 million on FedEx. I'm now going to build this FHIR-driven app that will save you $10 million. Would you gain share with me? Oh, just $1 million or so. Zimmer would say, well, that's great, of course. So there's an amazing business model for these young folks who come up with these EHR supplements, these apps that layer on top of the EHR using FHIR. And at Beth Israel Deaconess, we've called that strategy EHR Plus. So here's a challenge that I have. We're doing a $5 billion merger currently at the Beth Israel Lahey Health System. And do you know that healthcare gets better by getting bigger? I mean, everyone's figured that out, right? Merger's good. I have Epic, 3 different versions, sitting at some hospitals. I have Meditech, 3 different versions. I have Athena. And Jocelyn just bought Cerner. And so people are saying, oh, I know what you're going to do is you're going to rip and replace everything from everyone and put in one giant monolithic EHR because that will solve all your workflow problems. Well, that might be true if I had $2 or $3 billion and I had the temerity to tell 40,000 employees that I would change their workflow, which you can imagine Since CIO does mean career is over, I could do that, but maybe I don't want to do that. So instead, what we've said is, oh, Epic FHIR enabled, Meditech FHIR enabled, Cerner FHIR enabled. Why don't we just create a suite of apps? And by the way, we make them device neutral and OS neutral, so they run in Android and iOS, that enable providers and staff to have the appropriate workflow and experience on their app, regardless of the underlying transactional EHR in their location. Does it solve every problem? Well, no. Of course, there are other things I have to do, aggregate data for quality measurement, et cetera. But this is a strategy that is going to enable me, at least for the next 5 years or so, to keep in place the EHRs post-merger and give people a unified experience without spending several $billion. But there are a few tools that we need. And I imagine that as we think of the next generation of some of the FHIR work you're doing, this potentially could be a service out there. So we have the challenge in the United States that we don't have a nationwide patient matching strategy. Now, you don't have that problem because, of course, everybody gets a canonical identifier, and you track their data against that identifier. Wouldn't that be great? Well, of course, I don't want to make any political statements, but for the next 2 years, 7 months, 8 days, and 2 hours, we're probably not likely to have major regulatory change and create a national ID. I'm just guessing. And so you're going to need some kind of service that is callable with some number of data elements that will help us track patient identity. And those of us who've worked in this field know that demographics alone probably aren't going to be sufficient. So you guys are actually staring at South Boston. So a real case. Turns out there's a lot of Irish Americans that live in South Boston. Maureen Kelly lives in South Boston. And Maureen Kelly was born in 1951, and she's a patient of Beth Israel Deaconess and Atrius, which is a multi-specialty group, and the Brigham. And she came to us for care, and we had to match her medical records at the Brigham, Atrius, and Beth Israel Deaconess, Maureen Kelly, 1951, South Boston. Do you know that in the last year she's had 3 kidney transplants, a brain tumor, and twins? Why? Literally true. There are 5 Maureen Kellys on the same street with the same birthday in South Boston. It doesn't work. And so you can imagine a FHIR service where it's not only name, gender, date of birth, but it could be other data like referential matching. What was the first car you had, or the property you owned, or what's your relative's name? Other things that are going to help us figure out who the patients are. So we need that service. Well, in the Obama administration, and many of us were involved in this, we created ways of sending data from place to place. But the only problem is that we never had a directory of how to get it there. So I really call this, we told doctors they had to drive, but we didn't build any roads. And then we held them accountable when they didn't get there. Well, that's a problem, right? So I imagine, again, in Europe, you probably have canonical directories of providers and hospitals and electronic addresses. And we don't have any of that. Right? So shouldn't you have a FHIR service? It's not only who is the patient, but who is the doctor, and how do I reach them, and what is the URI of their endpoint, or something like that. Then another problem we have, and I'm just trying to enumerate some of the real-world use cases, is anyone from New Hampshire? Okay, so live free and die state. I just love it. Oh, it's actually or, but you don't have to wear a seatbelt, and the liquor stores are on the freeway, so I don't know that, and it may be true. We've recently opened up some clinics in New Hampshire, and you would have thought, because New Hampshire hates government, that it would be actually really easy to send data across the New Hampshire-Massachusetts border. Well, it turns out, actually, New Hampshire doesn't make a lot of laws, right? The legislature is only in session 90 days a year, because those rascals would otherwise make laws, right? Exactly. So here's a problem, is that in New Hampshire, it turns out there are different policies for consent, different policies for what data can be shared for what purpose than Massachusetts. And so very, very I mean, if you're living in Massachusetts and you got New Hampshire and you got Vermont and you got Rhode Island and you got New York, how are you supposed to coordinate care? Well, again, what if there's a FHIR service that enables us to enumerate patients' consent preferences, regardless of the state they live in? Well, then suddenly we can start sending data across the border a little bit more fluidly. Or even if you couldn't do that, I mean, just as Apple has tried to do, create a container by which the patients start to be stewards of their own data. I get the data from my provider, and then from that container, I send it off. And again, all FHIR enabled bidirectionally. That solves a big policy problem, because in the US, yes, we have 50 different states, which means we have 50 different policies. Actually, 6 territories, so we got 56 different policies. We also know that as we move from fee-for-service to value-based purchasing, we're being paid for outcomes and paid for quality, not just for ordering more tests. And so what that means is we have an imperative to coordinate care like never before. So it used to be that the Mass General, anybody from Mass General? See, Mass General actually thought of its data as an asset because it's accumulated millions of patient records. But today, we can't survive in a risk-based reimbursement environment unless we share data with each other. So you suddenly need to build these APIs on the edges of every provider network to be able to coordinate a patient's care so you get the right care at the right time for the right patient, improving quality and reducing cost. And this is the statement I was making about government. I don't think government's going to lead the charge. I mean, government can convene and government can be supportive, but I don't think, I mean, Chuck and I were in 200 meetings with the Obama administration. Government drove the agenda. And now I think it's you guys who will drive the agenda, and government will just lend their support. So really, I really think the private sector, the innovation economy, is where the action is for the next couple years. Okay, whoops, wrong button, sorry about that. So let me give you some other examples of where FHIR has truly practical uses. So has anyone parked in this building? Because you'll notice that the parking fee is $43 for the first 80 minutes or beyond. Yeah, welcome to Boston. And so in fact, it turns out that this is the nature of parking in our downtown region, 43 bucks. So imagine you've got a simple medical problem and you want to go see your provider. Well, again, anyone who's from our region, you know that we don't measure speed in miles per hour. We measure it in hours per mile. I mean, right? If people ask me, well, you live 20 miles to the west, how long is your commute? The answer is between 35 minutes and 3 hours. Right? So commuting is awful, parking is expensive. So don't we want a different way of delivering care than requiring every patient to commute to some downtown medical center? My wife, a few months ago, said she's had an unexpected weight loss, chronic, not acute, wasn't a GI thing. She's had a heart rate elevated, and again, chronic, not acute. Her eyebrow hair was falling out, and her hair was very brittle. So what I've just described to you is thyroid disease, very typical symptoms of thyroid disease. So instead of hopping in a car, driving for 3 hours, and paying $40 for parking, she pulls out her mobile app and then does secure text exchanges with her clinician and says, these are the signs and symptoms. I think it's probably a thyroid problem. What do you think? Clinician texts back, yes, you need certain laboratory evaluation. And she gets a TSH, a T3, a T4 at the neighborhood Quest just right down the street. Quest sends that data to her phone. And of course, we all knowing that there are apps and iOS capabilities, you should be able to see that natively. And it's all FHIR based. And now she sees, oh, I actually have a TSH of nothing, a T3, a T4 that's 5 times normal. It's a hyperthyroid problem. So she asks her clinician for a referral. Actually goes and sees a clinician in the suburban location, free parking, and then gets diagnosed with Graves' disease. The medications are prescribed to the Walgreens 25 feet from our farm. She takes them for 2 weeks, and her symptoms are all resolved. So all good. So think about that interaction. It was primary care, specialty care, laboratory, pharmacy, patient, and family all done on the phone without having to drive or park. And that's the kind of care all of us want. And you can think about that workflow, how much of it is FHIR enabled. Or another example for you. Chuck's not going to believe this, but because he's been out to dinner with me so many times, and I eat only rocks and sticks. I've been vegan for 25 years. I run a farm. I have a body mass index of 21. But yet I was diagnosed with hypertension 6 months ago. Because although you can choose your diet and choose your exercise, you can't choose your parents, it turns out. So I was asked by my primary care doc, could I take Internet of Things devices and use a Withings blood pressure cuff, measure my blood pressure and pulse, look at my activities of daily living, my stress levels, give my doctor all these measurements. And again, not having to drive into Boston, not having to pay for parking, I was able to do this in my home, gather the data, send the data to my phone, and then from my phone with an app, send it into the EHR. Again, the sort of FHIR-enabled workflow that we want. My clinician was then able to do two important things. First, diagnose me. It didn't have to. In this particular case, he was concerned, did my blood pressure vary when I commuted or when I met with my boss or when I drank green tea? Was it situational or activities of daily living? And the answer is no. It's just primary hypertension. But the most important part is he then decided to give me a high blood pressure medication, metoprolol. And I don't know if anyone's ever been on a beta blocker, but if you've had a cup of coffee this morning, imagine negative coffee. Right? Metoprolol is like 2 negative espressos. It's like you're really tired, in a bad mood. So what I was able to do with my phone and my devices was correlate. I took these medicines in this dose, had this blood pressure and this pulse and these signs and these symptoms and this mood, and feed that back to the clinician. And we were able to iterate by sending data back and forth over a few days to get me from 50 milligrams to 25 milligrams to 12.5 milligrams. And that normally would have taken weeks of feeling awful. But because of FHIR's ability to transact data bidirectionally, you can wildly reduce cycle time and improve the patient experience. Now, I know at this conference you're probably also going to be discussing flat FHIR, I would guess. I think probably Josh or somebody is going to talk about that. So although every example I've given you to date is a single query response, show me the patient, show me the doctor, here's a lab, I'm going to coordinate something about a schedule, there is a need for bulk exchange. And in the example of my wife, how was it that we did her cancer treatment optimization? We used an open source tool called I2B2, which Josh and some of you may have been involved in, to send queries to the data and get responses about patients like my wife. So certainly it's going to be important to think about these bulk exchanges that go beyond just a single patient query. And those are, of course, FHIR standards that are our work in progress. Just to show you, here is the app that we developed for our patients, FHIR-based. And obviously, some of the things we do don't quite yet have FHIR implementation guides, so we had to hack those together. But the idea is for every patient, you show them, based on the EHR care plan, what is it you're supposed to do today? What are the meds you're supposed to take? What is the exercise you're supposed to do? The diet you're supposed to eat? What are the Internet of Things measurements from your home? Your blood pressure, your pulse ox, sleep apnea monitor. And then once you have objective and subjective data, you can then ask patients, how do you feel? What is your mood? What is your mobility? What is your pain? So imagine a situation where a patient with congestive heart failure stands on a bathroom scale and they've gained 10 pounds of water weight in a weekend. And they haven't taken their diuretics. And they're feeling short of breath. You then say, aha, you're having a congestive heart failure exacerbation. We're going to send a nurse to your home right now, and we're going to double your Lasix, take away your salty snacks, provide you some education, and we'll get you better without having a $20,000 hospitalization. And again, you wonder why we need to do this. Well, in a value-based purchasing world, it is absolutely true that a congestive heart failure exacerbation hospitalization is a $20,000 expense. But remember, I'm now being paid for quality and outcomes on a fixed budget. It's far cheaper to use FHIR-enabled apps in the home, buy bathroom scales for these patients, and have visiting nurses take care of the problem before a hospitalization. So we're absolutely incented to buy these products and services. So for FHIR entrepreneurs, I want to buy these things in lieu of just seeing people readmitted to the hospital. And then we try to show patients some insights. Oh, you didn't take your meds. You felt worse. Let me show you the correlation. And give them, in effect, it's like a WeChat or WhatsApp kind of communication across the care team. So again, sort of FHIR possibilities here. How do you coordinate care and build bidirectional communication of text? And the great joy of standards. Chuck, were you on the Continua Alliance back in the day? See, there was this promise that we would put together a coalition and that products and services would adopt certain standards. It never really got to where we wanted it to be. Yeah, but now your phone is the middleware device for every device you have in your home. And so I can take the data from the device to your phone and then through a single API, get it off your phone into the EHR for all the other kinds of things I've shown you. And so suddenly, it's almost as if every patient has an integration engine they carry with them. And that's really powerful. Well, a couple of other thoughts, and Chuck, don't worry. The Gartner Hype Cycle for 2017, the last one that was published, has a few technologies at the peak of inflated expectations. Blockchain, AI, machine learning, deep learning, 3D printing. Now, for any of you who are in the entrepreneurial environment, please don't give me a PowerPoint that says, we've created a cloud-hosted machine learning platform with Internet of Things APIs, mobile apps, and blockchain. I see these every day. It's depressing. But two things that I should tell you. I am the editor of Blockchain in Healthcare, a peer-reviewed journal. I became the editor-in-chief of that to tell everyone what blockchain couldn't do, because there's so much hype. I mean, Chuck, don't you just love this? Interoperability will be solved with blockchain. Identity management solved with blockchain. So remember, blockchain is just a public ledger you write to and can't erase. And it has some cryptographic enforcement of trust, and it's decentralized. So fine, we can all pick some use cases. Like, if you really needed an audit trail that was going to stand up in court because it's just not alterable and it's public, okay, maybe that's a use case. Or maybe we invent, I don't know, a micropayment model. Every time the FHIR API is used, you get, I don't know, 0.01 Chuck coin. I mean, who knows? Maybe there's a business model in micropayments to fund interoperability. Maybe, to the example I gave with New Hampshire, there's a way you use a blockchain to record consent preferences or something like that. But remember, as you guys develop your APIs, you're dealing with transactional throughput of thousands per second. And go Google blockchain Bitcoin throughput right now. And you'll see this morning the blockchain worldwide is at 2.7 transactions per second worldwide. That's not going to work so well for a highly scalable interoperability system. I don't know. And fine, there may be successive technologies that have better throughput. But when you hear blockchain, just remember, narrow use cases, not an interoperability solution, not an identity management solution. Maybe if you build a FHIR API to it, you did an initial coin offering, you could make billions. I don't know, but be very careful. Well, what about machine learning? Because you see that a lot. Okay, so this one I feel a whole lot better about. At Beth Israel Deaconess, we have a variety of prosaic problems. And remember, as Graham told me, I'm supposed to enumerate some of the prosaic problems to solve with FHIR. Well, it turns out, believe this or not, 25% of our patients don't show up to their outpatient appointments. Well, okay, why? Oh, they don't have a car, or they forgot. So imagine, again, we expose our appointment schedule to innovative companies, and they run an Uber or Lyft service, or they do reminders, or they take what is a FHIR-based API and turn it into something the patient can consume. Because maybe the patient doesn't have any internet connections at home, and they need a piece of paper, or they need somebody to knock on their door. But the point being that our interoperability work with Amazon, Google, and others in machine learning is all to solve these simple problems, like getting patients to their appointment, using the OR schedule more effectively, figuring out who needs an ICU bed, figuring out who is likely to benefit from a given medication or treatment. And so as we think about the FHIR enablement here, I think there's just a huge opportunity for taking the data about patients in the past, about patients' individuals' behavior, and then optimizing their care in the future by making the data available to developers. And I'm seeing a huge number of startups who are wanting to do this. So there you go. I hope that frames your day a little bit, that the world belongs to you. You'll have political support, not impediments. That you're going to be building apps that are FHIR-enabled, laying on top of transactional systems, and you're going to be solving some really basic problems in healthcare and workflow. And that's not just for doctors and payers, but importantly, it's for patients and people who are care navigators like us all. But let's look at our time. I think I probably have a few minutes to answer some questions. So thoughts? We've got some mics. Questions, issues. It's a hot room. People are sleepy, and the view is too good. Yes?
You're talking about transferring the data from a location to another location or making it available wherever it is needed. But what about the quality of the data itself? I'm sorry.
Sure.
What about the quality of the data itself? Because that no matter how good vehicle you have, if you do not have the right information getting transferred, it's not going to help out.
Sure. So let's talk about data quality for a minute, because he's absolutely right. We have a real problem with data quality. If you were to look at the underlying data of Beth Israel Deaconess, you'll find that gender is mistaken 3% of the time. Now, gender can be a fluid concept, so you can understand that, but most often it's because the registration clerk at 3 in the morning just didn't enter the data fields appropriately. And what about other kinds of data quality? So I have a meeting with Fitbit at 11 o'clock. Now, anyone wearing a Fitbit? I mean, it's a fine company, but just how accurate is that heart rate data from your Fitbit, especially when you're sweaty or the thing's sliding around on your wrist? It's like his heart rate's 20 right now. Should we call an ambulance? I don't know. Right? And so there's this sort of metadata that we need. Oh, it's a Fitbit. It's probably okay, because a minute ago the heart rate was 80, now it's 20, and it'll probably be 80 again in another minute. We can ignore it. And so we worry a bit about provenance, Internet of Things provenance. We worry about patient-generated healthcare data. What do we do with that? Do we commingle it with provider-based data, or do we put it in a segregated place? And how do we interpret it? How do we avoid medical legal liability? And then, of course, what can you trust? Even if there's another provider data source out there, is that provider data source to be credible? So I think your answer to this question is that we just need metadata around the data, and then we hope that maybe as a society we develop rules that say, oh, Fitbit, you're allowed to have variable heart rate. Medtronic pacemaker, you're not allowed to have variable heart rate. And then we can act accordingly. But yes, please recognize that all of the underlying data you guys are going to be working with will have its flaws, and you need to understand who gathered the data, what its appropriate purpose is. Because certainly as we look at different EHRs, they all have different workflows, and you might find in some EHRs doctors record the data, and in sometimes registration clerks record the data, and they may be of varying data quality. Yes? Yes?
Did you run into different versions of the FHIR API since you're having all these EHRs between the hospitals, and is that an issue?
Sure. So his question is, well, what about different versions of FHIR APIs? So you got your DSTU 2, 3, 4. And so I'm actually seeing companies sprout up that are FHIR-based middleware front ends that normalize variations in FHIR itself. You know, version control across different EHRs, et cetera. So sure, you know, we've run into that. I mean, as Chuck and I know, because we've been doing this for so many years, the thing that really gets you with interoperability is optionality, right? Variations in what is returned, variations in versioning. And in fact, at many of the standards committee meetings, Wes Rischel, our friend, came up with there needs to be a solution to this impedance mismatch problem because you can't upgrade everybody simultaneously. And so you know you're going to have to deal with this mismatch between various versions of a standard. So a middleware layer that deals with that. Or I think one of the things we used to quote at the standards committee fairly frequently was Postel's rule. And Postel, of course, one of the guys behind email said, send perfectly, but receive with ambiguity. Accept the fact that you're going to have a lot of variation out there. So it requires custom mapping of your APIs or middleware. Other comments? Yes, sir.
Kind of related to that, I'm going to paraphrase Randall Monroe of XKCD. You know, you look at something and you see that there's 7 different ways of doing it. You say, wouldn't it be great if it were standardized? And a year later now there's 8 different ways of doing it.
Right.
So from like a larger company, I work for a health insurance company, like how do you pick, like where do you say, okay, we want to put our ducks in this particular row when, okay, it turns out a year later there's going to be a much better one, and then 2 years after that there's a much better one.
Right.
How do you decide?
Sure. So I think that his question was the fact that technology is constantly changing and evolving, and it's hard to know where you should go and how many variations you should accept. So I come up with this sort of idea of smallest possible number. So if you look at Beth Israel Deaconess today, do we accept incoming HL7 v2.5? Of course we do. You must, because a lot of labs are still doing 251 exchanges. Do you accept CCDA? Well, of course you do, because it's a meaningful use requirement, and it's a lot of the transactions over the direct protocol that still happen. Do we accept FHIR? The answer is, yeah, we do. But we've tried to constrain it to the smallest number of standards, knowing that if there is a possibility of retiring something, you will. And sure, we're kind of aggressive in trying to push our trading partners forward a bit. And the state government has been a convener to try to help us do that. But you know, maybe if you're a larger company, use your market power. And let me give you the example of how we've used market power. We have an accountable care organization, $2.5 billion a year in risk contracts. We had 26 different EHRs in our community. And what we decided is that the smallest rational number, and you can figure out who they are, you know, Cerner, Epic, Meditech, Athena, eClinicalWorks, and we had to grandfather in NextGen because a bunch of community health centers use it. But we picked 6, and we said, if you want to work with our accountable care organization and want us to be your risk contracting entity, you must use one of these 6 EHRs. So skinny it down from 26 to 6. Still not perfect, but that's just an example of smallest number and use market power to try to drive that forward. Other questions? Yes?
Well, I'm wondering whether or not FHIRs are going to be able to bring down or remove bureaucratic barriers. I mean, I went and had an excellent in New Hampshire at St. Joe's, and then I went to Beauty Guy and Newport down at Southern Medical Center. And he couldn't see my x-ray because it's a different system, and both of them are totally electronic. 2 different systems, and if you don't, while you worked on the same system, it doesn't help you. So I'm like wondering, like, will you ever see like a central clearinghouse for FHIRs, or like they all go into
Sure.
possibly, work for it.
So our question is, well, there's technology, but then there's psychology, right? So how do we ensure that data flows more readily? So, okay, you guys are European. How many PACS systems does Scotland have? One. Just one, right? Every image in the entire country is put in one repository. And so interoperability, not so much of a challenge. What's the likelihood the United States could get to one PACS system? 0. Never, ever. And so, yeah, DICOM is a standard, and that's great, but DICOM was never really built for the age of the internet, and DICOM has its own extensions and optionality, and so there's that technology issue, but more important, there's the psychology issue. You know, the hospital isn't willing to make that data available fluidly, and there's probably a couple of reasons for that. So first, Devin McGraw is going to be speaking later today, I think.
Thursday.
Okay. So Devin is a wonderful, wonderful person who's extraordinarily practical, but she has left the Office of Civil Rights. So one of the challenges with the Office of Civil Rights is, and many of us in Boston have experienced this, is they say, well, gee, you better share the data for patient care coordination and quality, but you can never spill a byte ever, because then there'll be $1 million fine. So part of it is the hospital may be just a little bit unwilling to open up their data exchange for fear of a privacy breach and a fine. So how do you get around some of that? Well, Office of Civil Rights under Devin issued the following guidance. If you give the data to the patient and then the patient does whatever they want with it, no covered entity will ever be prosecuted. Oh, okay. So regardless of your state, regardless of policy, that is one nice way to sidestep some of the psychology issues. And some of it may still be competitive. You know, I don't want to share my data because it is my asset. And gee, I'll lose radiology income if I share this. But I think that's starting to fade as we move to these risk contracts and value-based purchasing. Now, you do mention images, because images are kind of a special case in some ways, because they're often so large. I mean, you're dealing with multi-gigabyte payloads. And so at least what we've tried to do in our region here is we get every provider to agree on a single cloud-hosted image exchange platform. And I don't own any stock in any company, and I'm not going to advertise any company, but Life Image happens to be a local company here. And Beth Israel Deaconess and Partners and Children's and all these providers have just said, if we're going to do transfers among ourselves, we'll just use this single cloud-hosted company and the DICOM standard. Everybody uploads it to one place, and then everybody can view it from one place. So that may also be in the interim until everyone is opening up their own DICOM exchanges and networks are fast enough, some common cloud hosting project. But it's more psychology than technology. Yes?
Earlier you were talking about like the type model, like blockchain and internet.
Yeah.
In your experience, are there any misconceptions of things that FHIR could solve that you actually think are sort of exaggerated, or do you think that FHIR isn't really approaching that overhyped area of the curve?
Well, so this is a question that probably Graham and some of you could answer better than me, but how many data elements are in an average medical record? About 5,000. How many have been FHIR exposed with all the DSTUs to date? On the order of hundreds, I would guess. Right? And so one misconception is, oh, we've FHIR enabled the medical record and therefore all data is all available for all purposes to everyone. Well, not quite yet. I was talking to one of our senators and I said, you know, Senator, what do you think interoperability is? And this senator said, every data element in your lifetime medical record exchanged for every purpose with every stakeholder for free in real time. Okay. Well, if that's your definition of interoperability, we could probably go home now because we're just not going to get there. So I think people sometimes think FHIR is that, and it will be, but for now we know it's marching through data element groups, use case by use case. And of course, it does need some other back-end services, which we're working on authentication and authorization and other things to supplement just the FHIR JavaScript object notation. So I guess maybe the answer is people think FHIR does more than it does at the moment, and there's maybe a tense problem of what FHIR does versus FHIR will do. But the trajectory is excellent. The project has been amazing so far. We just have to temper expectations a little bit. Okay, well, one last question, and then I think, do people get a break so they can fan off? Yeah, yes.
So I'm in the public health space. There's a lot about EHR vendors I don't know about. I'm wondering if you can elaborate. What's their incentive to open up their products to these FHIR-based apps?
Sure. So every EHR vendor I talk to, and they've all been around the table for the Argonaut project, recognizes the value of their product will be greater if there is an ecosystem of functionality around it, right? So that, would you buy an iPhone if it had no apps? Well, I guess I can make calls. But the value is that there's so many apps, and that's why I buy it. And Epic, Cerner, Meditech, they all believe that. The value and sticking power of their product will be greater if they're surrounded by developers like you. Oh, well, we got one last one over here. I know we're running. Okay, but it's Floyd. No, it's.
All right. So I love all the excitement. I love everything that's happening at these kinds of events. But assume you're speaking to the head of CMS, Medicare,
Yeah.
and the head of CDC. And advise them on when should they be moving forward with requiring FHIR in addition to or instead of their current standard use.
Sure. So Floyd and I have worked together for years on things like quality measurement and how it is that you can take some of these bulk concepts and apply them. And so CMS, I mean, we work with CMS for, decades, and so we know sometimes the government is actually the rate-limiting step because their capacity to receive the data is really not quite where it needs to be. So I guess my advice to CMS is if it's a bulk data extract, wait a little bit until the standards are more developed and more implemented. And you remember there was the paper that we wrote on measuring maturity of standards and adoption. Wait till you see a little bit of maturity and then build the capacity to receive it and only then make it optional and only after it's adopted make it required. Well, great. Well, thanks very much. You guys have a wonderful conference. Thank you.